Hello everyone, my name is Charles Arana, and today I would like to talk to you about this program in which we are learning a little bit related to medication-induced diabetes mellitus as a consequence of the use of novel cancer therapies resulting in hyperglycemia. By definition, diabetes mellitus is a disease in which the body is not able to produce, or in some cases, to respond to the hormone insulin, resulting in malfunction of the metabolism of the carbs and an elevated level of glucose in the bloodstream, which can lead to potential complications if not treated. For example, cardiovascular disease like heart attacks, cerebrovascular disease like strokes, neuropathy, nephropathy, retinopathy, peripheral vascular disease, which can cause obstruction of blood vessels and increase risk of amputation in patients. There are basically 6 types of diabetes. The type 1 diabetes, type 2 diabetes, gestational diabetes, modi diabetes, later diabetes, and type 3 diabetes. The first 3 types of diabetes are, we can say, the most common type of diabetes. Of course, the one that stands out is type 2 diabetes. That's why we are centering our attention in its risk factors. And first of all, we have the physical activity. That is maybe the most common a problem in our society. Then we have genetic factors, for example, having a first-degree relative with diabetes mellitus makes us prone to develop diabetes mellitus in the future. Of course, there are some external or environmental factors that contribute to it. Ethnicity is important. For example, African Americans, Latinos people, Native Americans, Asian Americans, and Pacific Islanders among the subset of population that are in risk to develop diabetes in the future, as well as women who suffered gestational diabetes in the past, and some medical conditions like hypertension, lipid problems, and of course, obesity. As we said before, the type 2 diabetes is the most common in the US population, making it around 77% of the US population. Then we have gestational diabetes with a 12%. Then the type 1 diabetes, which is more frequent in children and teenagers with an autoimmune etiology. And finally, with a 1%, the other type of diabetes, the less frequent diabetes, type of diabetes. Being diabetes a disease on the rise, we have 422 million adults having diabetes, which is tantamount to having 1 person in 11 with diabetes, and 1.5 million deaths caused by diabetes, making it a very serious problem of public health concerning. That's why we have a staggering cost of diabetes. Actually, there are around $327 billion spent annually in diabetes in America. It is incredible that every day around 4,000 people are diagnosed with diabetes. 356 of them undergo an amputation with the consequence of impairing, and 159 of them are in the end stage of kidney disease or renal failure, which necessitate very, very expensive treatments like dialysis, which is carried out 3 times in a week, 4 hours in a day. In this graph, we can notice that in people with diabetes, there are a higher incidence of ischemic heart disease, stroke, and of course we have cancer as a more frequent occurrence in this type of patient that in those who don't have diabetes. Regarding diabetes related to cancer or cancer treatment, we have to know that radiation therapy, steroids, and some types of chemotherapy may impact the blood sugar levels. That's why clinicians working with patients receiving chemotherapy for solid tumor cancer who actually have a pre-existing diabetes or a history of diabetes need to be aware of how the patient's glycemic level at the start of the treatment may impact the successful treatment completion. In this table, we can see the causes of iatrogenic hyperglycemia in cancer treatment. And by iatrogenic, I mean a problem that is caused by treatment or medical practice in a patient. Okay, so first of all, we have corticosteroid-induced problems. Then we have the mTOR inhibitor induced. These kind of drugs are being used to treat breast cancer. Then we have the immune checkpoint inhibitor induced drugs that are being used for the treatment of melanoma, lung cancer, pancreatic cancer. We have the resectable pancreatic cancer, and then we have pancreatic cancer resection as a cause of cancer treatment related diabetes mellitus. Well, our target audience are Caucasian males with history of cancer in need of chemotherapy that increases the risk of diabetes. These patients are those that were being treated with checkpoint inhibitors, for example. But first of all, I would like to mention there was a study where it was noted that the frequency of immune checkpoint inhibitor associated diabetes is reported between 1% and 1.8%, which represent thousands of patients who have received immune checkpoint inhibitor therapies. Well, our objectives in these programs deals with determining the incidence of diabetes mellitus in patients receiving checkpoint inhibitors as part of the cancer treatment. We have to keep in mind that around 1 to 1.8% of these patients are in high risk of developing or actually develop diabetes. This type of treatment with this novel therapy is a great breakthrough Most of the patients being treated with these checkpoint inhibitors are responding very well to the treatment, but there is an increasing rate of diabetes as a consequence of the use of this treatment. So that's why we have to monitor for complications after diagnosis. For example, risk of infection, which could make it worse. Of course, the risk of cancer recurrence. You have to keep in mind that it could be an early termination of the chemotherapy because of the hyperglycemia. And we have to educate our audience about signs and symptoms of diabetes once we start with the checkpoint inhibitors. And finally, we have to find risk factors that can decrease the chances of getting the disease. Of course, naturally, we have challenges. Maybe the most challenging of this is the non-compliance by the patient. I can say maybe this is the worst enemy of the physicians. And then we have a lack of literacy. Sometimes the level of education of the academic level is completely relevant when talking about some issues and everything that is around this program. We have to keep in mind that some patients develop depression from the cancer treatment, and it can lead to a poor insight about the importance of monitoring for signs and symptoms of diabetes mellitus. Finally, we have lack of discussion with provider about potential side effects from the chemotherapy. Communication. One of the most important part of our program is the communication, in which the clinic visits with the oncologist that reminds patient about potential side effects from checkpoint inhibitors are paramount. We must use brochures and documentation about what to expect after starting treatment for cancer to better inform our patients. When talking to patients about cancer treatment, it is essential to have family, relatives, sometimes acquaintances involved, and to be active in the care of their family member with cancer. Remember that most of these patients suffer from depression, and they need all the support that we as providers or health educators, and especially the relatives, can give them. And last but not least, it is important that they can attend to group sessions where these patients can meet other patients with the same cancer treatment and diabetes mellitus to address their concerns and the way they face the disease. For example, eating habits and diet modifications and medication compliance. Regarding the management, we have to create a multidisciplinary team, which should include first the oncologist with extensive experience on these new diabetes-induced medications. Remember that this is a novel therapy, and there is no much knowledge about it. So these specialists must be well informed. And then we have the endocrinologist, of course, to evaluate our patient after his or she has been diagnosed with diabetes mellitus. It is important to include dietitian and a diabetes educator to help our patient with information on how to take care of their diabetes during the cancer treatment. We have to have nurses to teach patients on how to take medications for diabetes mellitus. For example, how to inject or inoculate themselves with insulin. And of course, we have to work with insurance to see if new technology can help with the management of diabetes mellitus. For example, the insulin pumps or insulin pens. Finally, our expectations, better control of diabetes mellitus in this subpopulation of patients with cancers, with patients with cancer, and decrease the risk of complications from uncontrolled diabetes mellitus during the treatment of cancer, and of course making people more aware of the importance of lifestyle modifications and medication compliance in the control of cancer therapy that induce diabetes mellitus. Thank you so much.